Good evening, all. On behalf of IACCM ICU Clinic, I welcome all the delegates, all the faculties, all the students, and examiners, respected examiners, for today's evening IACCM ICU Clinic. IACCM ICU Clinic is an initiative by our President-elect, Dr. Ranveer Singh Tyagi, sir, uh, where two students, IDCCM or DRNB student, present their case and exactly a real case scenario like exam, practical exam. Two national examiners, senior examiners, they ask both the students questions on the topic, so that it gives them a exact exam like feeling, so that it's just like a preparation for the final practical exam for the IDCCM and DRNB students. And every month on second Friday evening, 7 to 8 o'clock on Zoom, we have this meeting. And I feel that more and more of the students should join this, which is actually a real exam scenario and practical cases being presented. And for today's evening, we have two national eminent senior faculties examiners, Dr. Narendra Rungta sir, Dr. Ajit Kumar AK sir as examiner, and Dr. Pooja Murthy as the mentor, and Dr. Shuvas Bharadwaj Reddy and Dr. Ajit Kumar are both the students. They will be presenting case. And for today evening, the case presentation will be on Paraquet poisoning and OP poisoning. As ICU clinicians and intensivists, day in and day out, we get these cases in our ICU throughout India, and a lot of challenges are also faced, and a lot of patients, I say, die before reaching to the hospitals. And for the exam going students, questions on poisoning or a long case and short case on poisoning is a must. So I think today's case presentation by both the students and the questions by both the examiners will be an eye opener for all the delegates attending today's discussion. So I would like to welcome Dr. Narendra Rungta sir, who is the chairman and managing trustee, W4C Critical Care Foundation. He is the organizing and scientific chairman, 6th World Conference on Comprehensive Critical Care 2026 at Hyderabad next year. He is the chairman, Board of Governors, Critical Care Fellowship Program for Nurses, 4CN. He is the past president of Indian Society of Critical Care Medicine. He is the founder president of Association of SAR countries Critical Care Societies, and he is the past chairman Intensive Care Chapter IAP. And Sir is one of the pioneers in India for poisoning, and he is the chief editor of the book on poisoning. And the W4C Foundation has successfully organized the online course on poisoning, where students were enrolled and successfully completed the course. And Sir is also the pioneer for the position statement of ISCCM on poisoning. So I think he's one of the best examiners for this topic to do justice for the exam going students. So I welcome you, sir, for today's evening. And now I would like to welcome Dr. Ajit Kumar AK sir, who is at present the Vice Chancellor of Indian College of Critical Care Medicine. He is the Senior Consultant and Head Intensive Care Unit at Astor Whitefield Hospital, Bangalore. And he was the past College Secretary and Accreditation Secretary, Indian College of Critical Care Medicine, past Chairman, Indian Society of Critical Care Medicine, Bangalore chapter. And he's the editor of Journal of Acute Care and past editor of Critical Care Communication, ISCCM, editor and author at Start Pulse Medical Education Database, USA. And he has published 2 books in critical care, 1000 MCQs in intensive care, and handbook on complete COVID-19 care. And he was the organizing secretary of Global Intensive Care Symposium, GICS Bangalore 2022, co-chairman of Critica 2015. And He is a guide, teacher, and mentor to many of the students. And at present, he is at the head of the Vice Chancellor of Indian Society of uh, Critical Care College. So I welcome you, sir, for today's evening. And I would also like to introduce Dr. Pooja R. Murthy, who is the consultant critical care medicine at Astor Whitefield Hospital, Bangalore. She has done her MD, FNB, EDIC, and diploma in medical law and ethics by National Law School in India. She has done her ECMO fellowship by ELSO, and she has more than 18 publications in various national and international journals. So I welcome Dr. Pooja to today's evening scientific discussion as mentor to both the students. I welcome you, Dr. Pooja. I hope Dr. Bikram has also joined. I welcome Dr. Bikram Gupta to today's evening, who is the guide for both the students. And I also welcome Dr. Ranveer Singh Tyagi sir, who is the president-elect ISCCM. And this ICU clinic is his brainchild to today's evening. I also welcome my colleague Dr. Bhavani Prasad and all the delegates who have joined for today's evening. And I request all of them during the session kindly mute your laptop or phone. And you can share any questions on both the topics in the chat box. At the end, Dr. Pooja will be taking those questions, and by the panelists, it will be discussed. So, with this, I hand over the platform to Dr. Pooja to start the session and introduce both the students. Dr. Pooja.
Thank you, Dr. Anand. It's a pleasure to be part of the ISCCM ICU clinic, which is a very good initiative for especially exam-going students and trainees. So quickly to go to the today's session, we have two cases. One is on paraquet poisoning, and the other one is on organophosphorus poisoning. So first will be presented by Dr. Ajit Kumar R, who is a DRNB trainee from Manipal Hospital, Old Airport Road, Bangalore. He'll be presenting paraquet poisoning. And the second case will be presented by Dr. Subhash Reddy, who's an IDCCM trainee from Narayana Medical College near Guntur. I welcome you all to the session, and let's have a fruitful discussion. We'll do both cases together, that is one followed by the other, and then take the questions by the examiners. I would request Dr. Ajit to go ahead with the presentation. Please be mindful of time, 15 minutes for each case. Thank you.
Good evening, everyone. Good evening, dear teachers. I'm going to present a case on paraquet poisoning, and a 30 years old male, a 60 kg male who came with allergy history of consumption of 25 ml of 24% paraquet dichloride at around 4 p.m. Presented to outside hospital at 6 p.m. And initially gastric lavage was done with activated charcoal of 50 grams was given in the ER and referred to us for further management. This was the bottle found from the patient family with the milk weight. This is a brand available in India and with 24%. History of presenting illness. He presented the history of burning sensation in the throat and tongue, history of burning sensation in the hands and feet, no history of vomiting or abdomen pain, no history of breathing difficulty, no history of involuntary movements, no history of consumption of any other substance or food intake in the past few hours. Past medical history, no known comorbid conditions, no history of any psychiatric illness. In the personal history, non-smoker, non-alcoholic, non-vegetarian. He had a history of family issues like past few months. On examination, when he presented in the ER, patient was conscious, oriented, no pallor, no icters, no cyanosis, no clubbing, no edema, no lymphadenopathy. On presentation vitals, heart rate was 112 beat per minute, BP of 90 by 54, SpO2 of 96%, on-room air, respiratory rate of 20 per minute, which is thoracoabdominal, capillary refill time of 3 seconds. On cardiovascular system and respiratory was good. S1, S2 was here, no added sounds. And bilateral R&D was present, no crackles. Per abdomen soft, but there is a tenderness in the epigastric region. Local examination of oral cavity showing congestion in the uvula and the posterior pharyngeal wall, and there is a presence of nasogastric tube and redness over the tongue. Both eyes and skin was normal, no contamination of the skin or eyes. Point of care ultrasound was done, showing bilateral A profile, normal LV function, IVC of 1.5 cm with IVC collapsibility index of 60%, VT of 16 cm, liver and kidney normal size and echo texture. In ER, he was managed with the initial fluid resuscitation with the balanced crystalloids, 30 ml per kg. Routine investigation has been sent, including CBC, renal liver function test, serum electrolyte, ABG, ECG was done, chest X-ray was done as a baseline. Family informed about the need for intensive care management, and Goddard prognosis was explained to the patient family. Patient shifted to intensive care unit at 10 p.m. The day one of lab values, hemoglobin was 14, TLC of 10,000, neutrophil 80%, platelet was 65,000 at the initial presentation, blood urine nitration of 10, serum creatinine 0.52. Total bilirubin was 1.23, direct was 0.54, HGOT 10, HGPT of 15. ECG showing some sinus tachycardia, chest X-ray no parenchymal abnormality. The initial urine sodium iodide was positive. ABG showing no acidosis with the lactate 0.6, base excess of -4. No electrolyte abnormality. Sodium was 138, potassium 3.6, and chloride of 98. This was the initial X-ray at presentation. Patient shifted to ICU. In ICU, his airway breathing circulation was assessed. He was started on maintenance fluid, balanced crystalloids, 150 ml per hour, and hourly urine output was monitored. In ICU, he was started on injection proton pump inhibitor, multivitamins, injection NAC, injection vitamin C, and antacids through Priles tube. So in the day one, he started on cyclophosphamide 1 gram IV OD for 2 days and injection methylprednisolone 1 gram IV OD for 3 days. Hemoperfusion was done using hemoabsorption filter 230 on day one. A total of 4 sessions of hemoperfusion was completed within 24 hours. Urine sodium dithionate test was done after every HB sessions. It was negative, turned to be negative at the end of 24 hours. For the next 48 hours, he was assessed for the need of renal replacement therapy. At the end of third day, the injection methylprednisolone was stopped and started on dexamethasone 8 mg every 8th hourly. He was started on enteral nutrition through the NG tube, observed for any other new organ involvement over next 48 hours. So on the day 5, he was gradually improved over time with no respiratory and renal involvement. He was shifted to ward on day 5 in the hemodynamically stable conditions. He was continued on enteral nutrition and other supporting measures in the ward. The steroids tapered and stopped at the end of 1 week. The NGT was removed after 1 week and started on oral feeding. He discharged home after 10 days of ingestion. This was the investigations. At the end of 24 hours, burn of 18 and creatinine 0.8 and bilirubin was normal. No rise in, no transaminitis. There is a slight increase in the total count, 14,000 from the baseline of 10,000. Urine dithionate test was negative at the end of 24 hours and no acidosis in the ABG. And lactate was 0.5, basic was -1. At the end of 48 hours, the count was slightly decreasing, and 48 hours of post hemoperfusion, sodium dithionate was negative and no acidosis and lactate of 0.6. And creatinine was not rising, is 0.6. He was followed up till 3 months. He had no breathing difficulty, no swallowing difficulty, no decrease in the urine output. Follow-up X-ray was not done. Follow-up ogiriscopy was not performed during admission after discharge. Thank you.
Thank you, Dr. Ajit. Dr. Anand, I think we'll move on to the next case, right?
Yeah, we can take the second case.
I would like to welcome Dr. Subhash Bharatwaj Reddy, who's from NRI Medical College, Guntur. He will present a case on organophosphorus poisoning. Dr. Bharatwaj, please go ahead. Dr. Ajit, please stop sharing your screen.
1 minute. Sorry, levels.
Dr. Ajit, you can stop sharing the screen.
Yes, sir. 1 minute, sir. Sorry.
Dr. Subhash, you can start. Dr. Subhash, you are not audible.
Unmute yourself.
Dr. Subhash, are you there?
Yes, sir. Am I audible?
Yes,
Yeah,
yes,
yeah.
yes.
Please start.
Good evening, everyone.
You can put it in full screen, please.
Good evening, everyone. I thank everyone for providing me this opportunity. Today, I'm going to present a case on organophosphorus poisoning. A 43 years male with no addictions, no comorbidities, brought to our hospital here with alleged history of suicidal consumption of insecticide monoprotophos around 50 ml at around 3 p.m. at his own residence in Mangalgiri. He was brought to our hospital immediately within 2 hours. On arrival, his vitals were heart rate is 56 per minute, respiratory rate is 32 per minute. His blood pressure was 80 by 60 mm of Hg and his saturation is 84% room air. On examination, patient was drowsy and his GCS was E2, V2, M4. His pupils were pinpointed and we observed a copious secretions, profuse sweating and fasciculations. He had 3 episodes of vomitings on the way to hospital. Immediately on arrival to ER, he had an episode of seizure, which was treated with injection lorazepam 4 mg IV stat. And in view of poor GCS and threatened airway, after initial oral suctioning, patient airway secured with rapid sequential intubation. Injection atropine 2 mg IV bolus followed by doubling dose every 5 minutes was given till atropinization and later IV infusion was started. Injection pralidoxin 30 mg per kg loading dose was given, followed by 8 mg per kg per hour infusion was started, and IV fluids were also started. Gastric lavage was with activated charcoal at dose of 50 grams was done, and simultaneously his contaminated clothes were removed and skin was decontaminated with soap and water. After atropinization, patient was transferred to ICU. In ICU, he was kept on mechanical ventilator, assist control, volume control mode on FiO2 of 40%. He continued on atropine and palm infusions and IV fluids. He was hemodynamically stable and his ABG is within normal limit except for mild elevation of lactate. And on focus, there is a bilateral A profile and on flaps, there are basal V lines. No effusions was noted and his LV contractility is fair. The routine investigations showed mild leukocytosis in CVP and his LFT and RFT was within normal limits. Serum cholinesterase is 1030 unit per liter. On day 2, patient was on ventilator, is conscious, oriented, pupils mid-dilated and reactive to light. His both lungs was clear on auscultation and his vitals was he is hemodynamically stable. His heart rate is 102 per minute, respiratory rate is 24 per minute. His blood pressure is 110/72 mm of Hg and saturation of 100% on ventilator. His ABG is within normal limits. Focus showed bilateral A profile and no effusions and his LV function is fair. His muscle power was assessed, which was normal. All 4 limbs are 5/5. And he was extubated and continued on atropine infusion, palm infusion, and IV fluids. Patient was stable on oxygen support with face mask. On day 3, he was on room air, conscious, oriented. His lungs was clear. He is hemodynamically stable with maintaining heart rate at around 98 per minute, respiratory rate 18 per minute, and blood pressure 120/17 mm of Hg, and his saturation 97 on room air. The ABG is within normal limits. We started gradually on enteral feeds. Atropine infusion was stopped on that morning, and palm infusion was also stopped on the same day evening. On day 4, he was stable on room air. He's conscious oriented. His both lungs was clear on auscultation. He is hemodynamically stable with heart rate 96 per minute, respiratory rate 22, and blood pressure of 112/74 mm of Hg. And his ABG is within normal limits. By afternoon on day 4, patient complained of weakness and difficulty in breathing. On examination, he had proximal muscle weakness. That power was decreased from 5/5 to 3/5. He is unable to lift his neck. ABG at that time showed type 2 respiratory failure with PCO2 of 60. Possibility of intermediate syndrome was considered and patient was intubated and kept on ventilator. From day 5, patient was continued on ventilator and other supportive care. He is conscious and oriented. His pupils were normal size and reactive to light. On auscultation, bilateral basal fine creps was observed. He is hemodynamically stable and ABG is within normal limits. On day 6, patient had fever of 101 degree Fahrenheit and CBP showed elevated total counts of 21,000. His IV lines was reviewed and Foley's catheter was changed. On focus, we observed air bronchograms noted in left flaps. Chest X-ray was done, which showed left lower zone consolidation. And his ET secretions was sent for Gram-Stein culture sensitivity and started on injection peptides and continued other supportive care. This was his X-ray, which showed left lower zone consolidation, mid and lower zone consolidation. On day 7, he was continued on ventilator and supportive care. Fever spikes are still present and his total counts are still elevated to 32,000. His ET culture report showed Klebsiella, which is sensitive to meropenem, and antibiotics was changed to accordingly. This was his ET aspirate culture sensitivity report. On day 10, as patient was not able to wean off from the ventilator and in view of thick ET secretions, tracheostomy was done on day 10. Subsequently, his fever was subsided and muscle power was improved and patient was gradually weaned off from ventilator to oxygen support and onto thermovent and patient was mobilized and shifted to ward on day 14. In ward, patient was hemodynamically stable. Tracheostomy was decannulated on date 16 and he was discharged after psychiatric consultation on day 18 in stable condition. Thank you.
Thank you, Dr. Subhash. Now I think we will allow the examiners to question. We will first take Paraquet poisoning. Rumta sir and Ajit sir, please take over.
Rumta sir, shall I start, sir?
Yes, Ajit.
Yeah.
Please.
Yeah. So Dr. Ajit has shown a rosy story of a deadly poison. So what I want to just highlight is that, this patient appears to have a reasonably smooth course and, went home. That's what's like, appears to be a very uneventful story. But the real story is that there is often a very undue delay in, presenting, bringing the patient for attempts at an attempt. It's only attempts as appropriate care for these kind of patients. That is, you know, that's what's happening. So there'll be a lot of delays happening, and obviously the mortality is going to be, universally high for this kind of poison, depending on the level of poison. So basically, Dr. Ajit, I just want to ask you,
Sir,
yes, can you hear me? Yes. Can you hear me?
yes, sir, I can hear you, sir.
Yeah, that's fine. Yeah. So how does the initial approach to a paraquat poisoning is different from other poisoning? Anything you want to highlight? Initial approach.
Sir, as compared to the other poisoning, the timeline is very important for paraquat poisoning. Like a patient comes to us within 6 hours of presentation. With the history of Paraquet, they comes with the same bottle of that Paraquet. First, within 10 minutes we try to do the urine test. So from door to patient coming to us, as within 10 minutes we'll try to do the test positive. If there is a test positive, we'll go ahead with this patient actually presented with charcoal outside given. So we initially resuscitate with the fluids. On the other side, we're just putting a venous catheter for hemoperfusion. So first initial presentation as a gentle paraquat poisoning, we'll try to give activated charcoal within 2 hours of presentation, sir. Along the other side, we also resuscitate the patient based on the hemodynamic status.
So Dr. Pooja?
Yeah, that's what, sir. So I think the most important thing in paraquat poisoning is the time from poisoning to when we see the patient. So because there is absorption from the stomach, so initial gastric decontamination is very, very important. In fact, the first thing which they say is put a Ryle's tube carefully and remove all the food contents, because absorption of the poison will be going on if it is there in the stomach. And second is to use decontamination like activated charcoal. And the third thing is, if we have to use any heme adsorption or hemoperfusion filters, it has to be done in the first 4 hours, because the distribution into the tissues takes that much time. So after that, if we do, it may not be very useful. So I think this is how the initial management goes.
Yeah. So the paraquat poison is supposed to be the probably the only poison. Maybe some literature says the only poison where the decontamination is a priority over initial resuscitation or even transporting. So before you resuscitate the patient, even think about transporting. You try to decontaminate the patient. So basically, what you need to do is that it's not very easy. So naturally, you will not give gastric lavage, but probably, as Dr. Pooja mentioned, you can put a Ryle's tube. Obviously, if you're there on the spot, you at the site of the scene of the poison itself, you can give the activated charcoal, 1 gram per kilogram body you can give and try to reduce absorption. Even some literature says that if there is nothing is there, you can even give some food. Which kind of food is also that's also in an attempt to reduce the absorption. So basically here this is said to be probably one of the poisons where the decontamination is a priority over even resuscitation or even transportation. You need to do it on the spot. That's fine. And the second thing is, as you said, these are all time sensitive interventions. So you're done a HA 230 filter, basically, So there are some literature is there. So the literature, there is a Chinese literature. Many patients are put on that. 50% mortality was reduced by 50%. 50% mortality is still there. Obviously, need to be ideally within 2 hours. But obviously, the manufacturer is selling up to 6 hours. But that also be very time sensitive. Yes, sir. Sungta sir, you can ask something, sir.
Ajit, it was
Yes,
very
sir.
well
Good evening, sir.
presented case.
Yes.
Good evening,
I
sir.
have a few queries. What was the time of consumption? 4 p.m.
Sir, 4 p.m. is the time of
And
consumption.
he reached at 6 p.m.
6 p.m. she reached the hospital.
2 hours.
2 hours, sir.
And Ryle's tube was inserted by your ER team.
No, sir. It was inside outside hospital.
So,
Where they given the activated charcoal.
do you think the patient had gone to another hospital and reached your second hospital within 2 hours of the original ingestion time? Could it be correct, or there are lots of formalities that take place between two hospitals? So I really don't, there is no way that I will understand that the patient had ingested at 4 p.m., reached your hospital at 6 p.m. It
Patient
is
reached outside
difficult
hospital.
to understand, and in between there was another hospital.
So patient reached us at 9 o'clock in the night.
Your hospital.
Yes, sir. Patient reached the outside hospital at 6 o'clock.
Your hospital at 9.
9 o'clock,
With
sir.
the-
Yes, 9 o'clock.
After 5 hours.
Yes, sir.
And what is how did you confirm that it was 25 ml?
Sir, what patient was conscious? So she told the amount of poison she has ingested, like one mouthful of she has taken poison that contain nearly 25 to 30 ml.
And she had just signs of shock, hypotension, nothing else.
Minimal hypotension was there, sir. That was managed by fluids initially.
And you gave 30 ml per kg balanced fluid for that.
Yes, sir.
Was it the correct dose? You said she was only mildly hypotensive and required 30 ml per kg. Was she in shock, or she
Not
was
in
just
shock, sir.
hypotensive?
Minimal hypotension, not in shock, sir.
So 30 ml per kg, was it the right dose?
Sir,
Or it was not required? I just want to understand.
sir, patient was in NPO since the afternoon.
No, that's okay. I'm discussing the amount of fluid that you gave to the patient.
So for
Was
any poisoning,
in shock or was hypotensive? And you said mildly hypotensive. Would you
not in
give
shock,
that
sir.
amount of fluid to a mildly hypotensive patient, or that is recommended fluid for a shock patient?
So as in any general measure of poisoning, we start with
No, answer my question.
yes, sir.
My question is, was your patient in shock?
No, sir.
You say no.
No, sir.
Then how much dose of fluid you need to give to such patient? Mildly hypotensive patient.
15 to 20 ml per kg.
You gave 30 ml per kg. That's my first question. Number
Sir,
two, yeah.
In these patients, mainly paraquet poisonings, the maintaining your output and the renal performance.
Don't mind, I'm just being a approved examiner, maybe rude examiner, from the point of view that when finally you face some externals, you are ready with, your good answers. So your fluid therapy was somewhere different from what it was needed. You agree with that?
Yes, sir.
Right. Number two, you have not described anything in mouth. Oral ulcers, Paraquet tongue.
Sir, oral ulcer is not there. It was kind of congestion over the tongue and the posterior wall was there.
And the patient went into shock. Nothing in mouth, no tongue problems, and patient was hypotensive. Now you gave cyclophosphamide and methylprednisolone to the patient. What did this patient need? What was the basis for giving methylprednisolone and cyclophosphamide?
So there's a involvement of initial lung PO2 is less than 80. So
what is the indication for giving cyclophosphamide? Which patient should receive cyclophosphamide, if at all? If at all. It's just a speculative therapy. You and me both would agree on that probably. So what was the best indication to your mind for initiating methylprednisolone and cyclophosphamide therapy to this patient? Do you think at least cyclophosphamide is not a very sick drug? What was the indication? And what was the indication in your patient, and what are the usual indications?
Sir, the indication in my patient is the presence of a positive urine diatonic test, which indicate the plasma level of paraquat more than 2 milligram per deciliter, basically. So I just
And you say the patient had consumed only 25 ml.
Yes, sir.
Do you expect a positive diatonic test in patients?
25
And
ml.
the patient cleared everything in 4 cycles of hemoperfusion? No hemodialysis was done simultaneously?
No, sir.
So, Dr. Ajit, yeah. So, what is your target
No, let
oxygen?
me complete, Ajit.
Yes, yes.
Yeah. Ajit,
Sir,
what is
dialysis
the
was,
indication for methylprednisolone and
sir, routine immunosuppressant. In some
what
trials,
for? What for? Immunosuppressing what? What was happening to the patient? Patient was not having even renal dysfunction. There was no fall off. The patient did not need any ventilation. Patient did not have any respiratory problems. What is the indication for immunosuppressive therapy in Paraquet poisoning?
It is indicated only when the lung is involving.
Yes.
Due to denying lung proliferative or fibrosis stage. That is the indication for the
So every patient of Paraquet poison, you see 20 ml is a, it is not a, it's a mild poisoning if at all. Usually it should not show positive diethionate test in urine. Usually anything can happen in medicine, but it's unusual that 20 ml consumption would lead to. Number 2, gastric lavage decontamination, it's avoidable. Only charcoal only within 4 hours, only within 2 hours. Now patient reached you in 5 hours. So again, there was no indication for charcoal. Right?
yes, sir.
So, and I'm surprised that patient became negative with 4 cycles of hemoperfusion. That again is contrary to what we understand, what the literature talks about Paraquet poisoning. So be careful.
Yes, sir.
That should be, I think, does not sound to be factual.
No, sir, more than 20 ml is very dangerous. If
40 ml and beyond 25 ml is as good as 20 ml. 20 ml is mild poisoning, and most of these patients should come out.
Below 10 ml is mild.
Description you have, the description in literature is 20 ml is less is mild, 20 to 40 is moderate, and more than 40 is severe. But it is very, very difficult to measure what was the quantity consumed. Mostly the definition is formed later on the basis of clinical symptoms and signs and progress of the patient and the disease. Anyway, it was a good presentation. You presented it very, very crisply. That is good.
Thank you, sir.
But you should be very careful in putting things together. In this case, methylprednisolone and no immunosuppressive therapy was needed. Now,
Yes.
one theoretical question, what is the most dreaded complication of Paraquet poisoning?
So lung fibrosis.
Right. This patient did not show any evidence, was
No, sir.
discharged very early without any problems.
No, sir.
That is
Long-term
great.
follow-up was also good.
Thank you, sir.
What is the, would you recommend a patient suffering from Paraquet poisoning a lung transplant at STEMITAS who had full-blown presentation of Paraquet poisoning?
Sir, a patient present to us with a full-blown paraquat poisoning with a multi-organ dysfunction.
And he recovers and he's on sort of supportive care, and you prepare him for lung transplantation. Would you recommend?
The patient
What
comes
is
with
your understanding about lung transplantation in patients suffering from Paraquet poisoning, late fibrosis?
Sir, late fibrosis, we can go with a lung transplantation if patients survive the initial presentation. If patient gone into modes and patient die early, we can't do anything. But if patient present late in the lung fibrosis,
Have you gone through any data about that?
sir, I have gone through some data of lung transplantation which gone into allograft failure.
Future lungs will also have, new lung will also have fibrosis.
Yes, sir.
So
Therefore,
yes,
We are
to
reporting
answer
increase
that
in the paraquet
question,
level.
allograft failures because of recurrent paraquet poisoning in
Yes,
the
sir.
allograft itself is a major concern. So that is
Right. So it's a tricky thing to do and recommend. The patient should be told very clearly there is a strong possibility of recurrence of new transplanted lung. Thank you. Ajit, you
Yes.
can take over.
Yeah. So what is the target? Some basics again. What is the target SpO2 in this kind of patients, Dr. Ajit?
Sir, target SpO2 we can keep even 85 to 90% until at least the anaerobic metabolism ensues, causing lactic acidosis to be happening.
Yeah.
So even 85% we can accept in these patients.
Yes, yes. So basically, regarding the cyclophosphamide and methylprednisolone, it is given as an immunosuppressant immunomodulatory therapy. But as you said, the strong, high quality evidence is lacking. Basically, it's under the claim of, whatever the belief of the reducing the mortality, but there is no strong, evidence for that. Even one Cochrane analysis, I don't know which year it is there. Basically, they have shown that there is a very low quality of evidence to recommend it, routinely for this patient. But in this poisoning, people are very desperate, people do try, sometimes I agree with that, yeah. So regarding the lung transplant, you should be very sure that all the other areas are cleared of thing. You cannot have a slow release of, another, again, it should be very clear. There shouldn't be any later release, slow release of the poison. It should be very clear that it's totally cleared off of the system. Then only even you can consider from that. So, by the way, you know any nomogram, just for a few academic questions, you know any nomogram which has been used for this poisoning?
Yes, sir. We have a nomogram called SIP score, the severity index of paraquet poison score. We consider two things in that: the time of ingestion in hours and the plasma paraquet level. Like we have to multiply both the score and we get a score of more than 10 is increasing mortality. Patient likely to survive if the score is less than 10. The Proudfoot score is nomogram is there. In that we can draw and know the mortality and poor prognosis we can explain to them.
Dr. Pooja, you want to add anything, madam?
That's what, sir. I think being aware that it is a very deadly poison, and of course, like Dr. Ajit presented a good outcome, even in our experience, we have also seen some good outcomes. But majority of the times, everyone experiences very poor outcomes in terms of significant parakeet poisoning. And early decontamination, early hemoperfusion, if there are options, we should definitely go ahead. And most important thing is we should avoid oxygen and watch for features of progressive worsening. Lung transplant plus or minus, because in severe lung fibrosis, there is no other option other than lung transplant. But unfortunately, rejection rates are also very, very high because of recurrent poisoning. So I want to summarize in this way.
So what kind of particular test we do to detect, the paraquet when you do the XA230 filter, the resin-based filter, hemofiltrator filter?
Okay, Dr. Ajit can answer.
Yes, sodium diethionate test we regularly do. Plasma paraquet level is not available everywhere. Only in few centers having plasma paraquet level make time also. It may take more time. So this one test available in bedside, we can do it in bedside, sir.
So can we go to the next case, sir? Dugdha, sir?
Yes.
Yes.
Dr. Subhash?
Yes, madam.
Sir, please take over.
So, Dr. Subhash, yeah, let me start from. So, you had some pinpoint pupil, am I right? Pinpoint pupils.
Yes, sir.
Yeah. So, you can just tell us the differential diagnosis of pinpoint pupils for everybody's sake.
Sir, another
Patient is coming in with unconscious state with a pinpoint pupil. Yes.
Sir, opioid poisoning is one of the DD, sir. Pontine hemorrhage. Sometimes severe alcohol intake also cause constricted pupils.
So three post-spontaneous hemorrhages you are told. So when you have a doubt regarding whether patient has taken, the OPC or not, what will you do? What are the things what you can do? Obviously, you should have a quick history, examination, everything you do. But anything you can do when you have a doubt regarding the nature of the poison? You find a patient with a pinpoint pupil, you don't know what the patient has taken. It's an unknown patient, whatever. There is no history available. Any intervention, any test you can do for that?
Atropine challenge test, sir.
So how much atropine you will give?
So 0.6 to 1 mg IV stat dose, sir.
Mhm.
If there is any rise in heart rate by 20 to 25 minute per minute, it is unlikely organophosphate formation.
Mhm. So you look at other symptoms as well, mydriasis, those kind of things you'll see. Isn't it? Tachycardia.
Yes, sir.
You look for all that. Am I right? Any
Yes, sir.
blood test or something? People sometimes we send it actually. Any particular
Yes,
blood test?
yes, sir. Estelle cholesterase, sir.
Mhm.
So actually, what we do is pseudocholesterase measurement, sir, because RBC cholesterase is not available in every center. So we send for plasma cholesterase.
Mm. So what is the endpoint of atropinization?
Sir, mainly,
See, when you do atropinization, I would like to know that when are you going to start atropinization, when are you going to stop atropinization? Some rough idea, for the audience, our people, yeah, yes.
yes, if patient is having bronchoria and bradycardia, we have to start immediately with atropine of 2 mg stat, followed by for every 5 minutes, doubling the dose of atropine till we reach atropinization. And the target of atropinization is dry lungs and heart rate more than 100 per minute. And others like systolic BP, reactive pupils.
The heart rate more than 100 per minute, maybe 200 also, isn't it? So maybe I will say that maybe more than 80, maybe okay, isn't it?
Yes,
80
sir.
to 100,
Around 100.
that's, yes. So what is the difference between your glycopyrrolate and atropine?
So atropine can cause a blood-brain barrier, but glycopyrrolate do not cause a blood-brain barrier. But efficacy-wise, both are same, sir. So if any complications occurs with atropine infusion, we can change from atropine to glycopyrrolates.
Yeah. So naturally, the atropine psychosis, the psychosis is very, very extremely unlikely to happen. Atropine psychosis won't be there. Second thing is there is one RCT many years ago showed that some kind of a ventilator associated pneumonia was, a little bit less than a glycopyrrolate. But again, there is no strong evidence for that. So yes, yeah. And if you're supposing you give one patient atropine, it's not working. Any other medication you can try for that? Patient is having bradycardia, your atropine is surprisingly not working. You tried atropine a couple of times. It is not working. Any other medicine you can try? Any studies, anything?
Adrenaline infusion, sir.
Yes.
Mild dose of infusions.
Mm-hmm. Yeah. So why this patient whom you extubated again had to be reintubated?
Sir, because of respiratory muscle weakness and mainly because of respiratory muscle weakness, sir, and other features like proximal muscle weakness, and he is unable to lift his neck, mostly favoring of intermediate syndromes. So that's why we intubated the patient again.
So do you use PAM in your practice? PAM?
Yes, sir. If patient present to us within 2 hours, generally, we start with PAMs.
So Dr. Rumta sir, Dr. Pooja madam?
Rumta sir, please take over.
Yeah, Subhash,
Sir, good evening.
my understanding is monoprotophos is banned in India. It cannot be sold in India. Do you want to see on Google? It cannot be sold in India because it is one of the most toxic OP compound.
Yes, sir.
And what it does more than harming the human, why it was banned? It was not banned because it was harming the human beings in India. It was banned for some other problems. It killed a lot of rare birds. You see, so I'm surprised that you had a patient of monocrotophos poisoning.
Yes, sir.
We have not seen any monocrotophos during last 20 years. One. Number two, I understand in South India, people seldom use palm. You, for an exception, have used palm. Any particular reason?
Sir, because he presented to us within 2 hours, sir. So that's
No, whatever south of India, we are given to understand most of the centers don't use palm at all. Beyond
Is there any
Vilyas.
connection with India? Is there any connection with India, man? This OPC studies, OPC poison, anything you can connect with India? An India study,
yes,
Indian
sir.
data?
Pune Baramati study shows some
There was
advantage.
Baramati study is okay, but
before that.
are there any strong Indian studies closer home to you?
No, sir.
Somewhere in South India.
CMC Vellore shows.
CMC
Yes, sir.
and
CMC.
even Tamil Nadu, they hold Tamil Nadu and lot of colleagues, they are very strong opponents to palm use.
Yes, sir.
During last 10 years, we have treated almost 65-70 cases of OP poisoning without palm. We used to use palm regularly before that, and since 2015, I suppose, we have not used palm in a single case, and there are 100% survival. Now, during your recovery period, presentation you said patient had fasciculation, some problem with consciousness. During progress and monitoring, you did not mention about seizures, fasciculations, etc. What happened to that? Never occurred.
No, sir. Only occurred at the time of presentation. One seizure.
Why you chose not to send RBC anticholinesterase?
Well, it is not available.
No, it is available. Now in all big laboratories, this is available. But the report comes in about 2 days. It is available. Anyway, always it should be sent. Next, atropinization, you never consider pupil size. Pupil size as an important monitoring point for OP poisoning has been given a long back.
Yes, sir. Now only
Because sometimes
guidelines.
it may not dilate at all because of other reasons. So many drugs. You have given lorazepam 4 milligram.
Yes, sir.
That itself may come in way of pupillary dilatation.
Yes, sir.
So atropinization means heart rate above 100 and
dry lungs.
Dry airways, not
Dry
dry
airways.
lungs. Now, what was the cause of pneumonia?
Sir, probably ventilator.
You never mentioned that your patient developed VAR.
Yes, sir. And
So
just
it was
pneumonia.
VAR.
Yes,
So
sir.
you should have clearly mentioned that patient developed VAR,
Yes, sir.
right? So it's a specific term. Now, so your patient developed intermediate syndrome very early.
Yes, sir. On 4th day, sir.
No, very unusual presentation. Probably, I think yours is the first patient I am hearing patient presenting with intermediate syndrome on day 4. Because the pathogenesis, that is the pathophysiology that is described with intermediate syndrome, it takes about a week since ingestion minimum. And patient comes back after discharge. Patient does not develop intermediate syndrome usually during the first admission. Patient will usually come after the discharge. So every discharge, patient should be explained possibility of intermediate syndrome developing.
Yes, sir.
So it was very early occurrence. Do you think you stopped atropine or palm too early?
No, sir. No, sir.
Did you give atropine and palm after the patient developed intermediate syndrome?
No, sir. Yes,
Why?
ventilator. no role of palm or atropine in intermediate syndrome, sir. If at all his heart rate is maintaining at around 100 and his airways are dry.
Would you agree that OP compounds have three types of actions: nicotinic, muscarinic, and central?
Yes, sir.
What is the intermediate syndrome? Where does the intermediate syndrome fall between the three?
Sir, nicotinic, it's a neuromuscular junction.
No. That's what it is. It's totally independent of all the three. It is neither central nor muscarinic, not even nicotinic. This etiopathogenesis is not known, but in certain compounds, Eldrin was famous for intermediate syndrome. Eldrin also has been banned in India. Begon was also one compound which was famous for intermediate syndrome. That also has been banned. So overall, would you like to try some cases without PAM?
Sir, yes, sir. We only give PAM if patient presented to us early, sir. If he presented late, we are not using PAM, sir.
What is early and what is late? How do you define early and late?
Presenting within 2 hours, sir, 1 or 2 hours.
And beyond 2 hours is late?
Yeah. Yes, sir.
What does the Baramati study recommend?
Sir, if ingestion of in moderate amount of
They say use only PAM even if the patient comes to you on day 4 or day 5. I met Dr. Pawar only 4 weeks back at Kolhapur. She becomes very aggressive with those who don't use PAM. Anyway, that's a different matter, but she recommends that PAM should be used in all cases of OP poisoning, irrespective of when the patient arrives. That is only for PAM users, not for a group like mine. We don't use PAM at all, but using PAM is, that's okay. You can use PAM. What is the dictum? How PAM should be used?
Sir,
What is the slogan, if you would like to sound one?
Slogan, I don't know, sir. But
Hit fast,
okay.
hit hard, and keep hitting. And continue to hit even after the patient recovers to make sure that it doesn't recur. Anyway, thank you very much. It was a nice presentation. And all those discussions and questions to both you and Ajit were only for academic purpose and not to pull your legs, only to give you a little more information about these poisonings. Whatever I understand, whatever experience I have, both of you did a good job. My congratulations to you, Pooja, and the whole team.
Thank you, sir.
For today's program.
So
Thank
Dr.
you,
Subhash, I'll just add one more. See, will you use, the PAM in carbamide poisoning?
No,
Why?
sir.
Why you are not using?
Sir, oximes won't work in carbamate, sir, because oxim remove phosphate from the organophosphate, but it is the carbonate group, sir.
See, usually the organophosphates are irreversible cholinesterase. They are reversible. It gets hydrolyzed within the next 48 hours.
Yes,
And
sir,
what is aging? I just want to stop my questions. Aging, what is aging in when you come to this poisoning? Aging of the compound.
With time, OP and enzyme complex loses one alkyl group and makes this complex not responding to reactivation, sir.
Yeah, so the irreversible binding of the compound with the acetylcholine receptor. So basically, what happens? The aging is happening. There are diethyl and dimethyl compounds are there. The dimethyl is supposed to age much faster. Reversible binding is going to happen much earlier. So many people believe that, as Dr. Rumthar is telling, there is a controversy there. When you're giving dimethyl compound, even if you give, some people believe that even if you give, PAM, it is not going to much of an effect. But diethyl, some people, even in South India, believe that, because up to 2 hours, there is no need to people who discourage palm. They believe that if the diethyl people, they come within 2 hours, still you can give in a palm. That's what, people believe. It's all related to the aging of the so-called aging of the compound.
And I have one advice suggestion for presenters. They should go through the guidelines of the Indian Society of Critical Care Medicine about poisoning and the position statement. Both, I think you'll find them very useful.
Yes.
And they are recent publications in during last 2-3 years.
Okay, sir.
So, Dr. Pooja, any
Yeah.
question for the audience? Yes.
Thank you, Rumta sir and Ajit sir. I think we really felt we were in an exam situation.
Few
And
questions.
Ajit,
Yeah,
yes,
sorry to interrupt, Dr. Pooja. I think a
yeah.
few questions in the chat box also. You can
Yes,
take
we
up.
have actually given some answers there, but I think we can put it up in the open forum. Uh, uh, so somebody has asked, what is the lethal dose of paraquet poisoning? I think Rumta sir during the session explained. Generally, we say 1 to 2 mouthful is a significant dose, that is around 30 ml or so. Lethal dose, generally they say up to 80 to 100 ml, 24% concentration. Rumta sir,
40 ml plus will definitely be a lethal dose.
Lethal dose.
Anything more than 20 ml is tricky, but
Yeah.
40 ml is definitely lethal.
Definitely lethal.
And most of the patients will have long-term morbidity, and most of them will die. Anything around 30 ml plus.
So 15 to, even 1 to 2 mouthful, up to 15 to 30 ml. 30 ml can be lethal, but there is some kind of a suggestions are there, which is again, if the person takes more than 100 ml of 20% paraquat, you can even palliate. I'm hearing for the first time, so palliating a patient. Patient has taken more than 100 ml and 20% paraquat mean you can consider palliation. That's what some literature is telling. So you can understand how lethal it is.
And I think straightforward question, what is the role of oxygen? Definitely we should avoid oxygen and do not target high
Pooja,
saturation.
I wish you to clarify why you are saying so. Please clarify to the
Yeah. So
participants.
the whole pathophysiology of parakeet poisoning is it causes redox cycling. It inhibits that, and consumption of NADPH happens, which it doesn't. I mean, it enhances the redox cycling in the organs which are affected, especially high vascular organs like lungs, kidney, liver, and heart. So the type 1 and type 2 pneumocytes absorb them, and the redox cycling will lead to production of super oxygen free radicals, which are called superoxide radicals, which will cause damage to the alveolar epithelium. So more the oxygen supply, more will be the production of these oxygen free radicals, which will lead to further damage to the alveoli. So that is why we prevent high oxygen delivery to the patient with paraquet poisoning empirically also. So that's the reason.
So Edaravone, obviously there is no evidence that Edaravone is ever going to be useful. There is no evidence. It is said to be an oxygen radical scavenger and all, Dr. Mahesh. So at the moment, we can't recommend an Edaravone for these kind of patients, OPC patients.
The other questions are what is the level of paraquet poison levels that should be achieved for lung transplant? Ideally, we should measure urine dithionate is an easy bedside test, but I think we should measure the serum paraquet levels. I think it's a little tricky to get it in majority of the labs. And Rumta sir, any insight? Ideally, I feel it should be 0, right?
No, you see,
Yeah.
Pooja, the right answer to this is there is no relation between plasma paraquat levels and indication for lung transplant.
Lung transplant.
Because the concentration of paraquat substance is almost 20 times more in
Tissues.
pulmonary epithelium.
Correct. Yes. Sir.
So to my mind, currently, these Paraquet patients should not be given an option of lung transplantation unless they are bent upon getting one done. We as intensivists should not participate into such programs until the air is clear and there is more light on the subject. That's my current understanding. It is always subject to more knowledge, more progress, and the current recommendation is this substance. Likewise, it has been banned from Europe and USA. It should be banned in our country also. That's the only cure of paraquat poisoning. And this hemoperfusion, because after ingestion, 90% of paraquat is passed in urine. Only 10% is left. And what percentage has already gone into lung epithelium is not understood very well. Therefore, to hasten diuresis, we should also take help of hemodialysis with hemoperfusion. So both the procedures should go on simultaneously. Hemodialysis and hemoperfusion to give little more chance, because 90% paraquat is likely to be excreted with urine within hours of ingestion. Therefore, whatever is left, because the very high concentration is deposited in the proximal convoluted tubules. Therefore,
Yes.
give these patients a chance with hemoperfusion, of course, but simultaneous parallel hemodialysis also.
Yes, sir. And coming to OP poisoning,
Dr. Pooja,
yes,
just one question from my side to you. As we discussed, you said you get a lot of paraquat poisoning cases at your place. So,
not lots, I mean, considerable, yeah.
no, so my question is that regarding that we discussed for that methylprednisolone and cyclophosphamide in the case also we discussed. Uh, I think it doesn't have any significant evidence for this use of these things. So, do you follow it at your center these things or?
Routinely, no, sir. Routinely, we try to add naive agents like vitamin C and all, because generally they are considered okay. If we have features of lung injury which has started, we generally add dexamethasone. And I don't think we swap between methylpred and dexamethasone generally. We start off with dexamethasone. And only in one patient who had significant ALI, and we had also used hemoperfusion and all the possible things. We also gave cyclophosphamide. So it is not a routine thing. If we have features of acute lung injury which is developing, then we add dexamethasone. But otherwise, if it is patient who is not having any manifestations of lung issues, we generally do not add.
You see, the international protocol which was developed mostly in China, because they had a very high incidence of paraquat poisoning, they attempted this combination: cyclophosphamide 15 milligram per kg body weight and methylprednisolone 1 gram OD for 3 days, and followed by dexamethasone 20 milligram per day. But that was all empirical. It has all been empirical, and this is again what we call probably ALI or ARDS. May not be ARDS, or the sequence of events from the autopsy indicates that the disease in lung progresses like ARDS does. There is a initial phase of inflammation, then congestion, inflammation and congestion, then proliferation, and ultimately fibrosis. But fibrosis part is very, very mild in ARDS. It's fatal in paraquat poison. Therefore, it's all, by the time start anything, lungs are already into stage of demise, and hardly scope is or any hope is left. All you are doing is going through the motions. So we really have to find out a good antidote to. When lactic acid accumulation starts, probably by that time mitochondrial injury has happened. And that's a hopeless situation because initially there is no lactic acidosis in paraquat poisoning.
Sir, in our experience for one patient, I think 3 patients we have used the HA230 filter so far in the last 6 months to 1 year. One patient escaped, lung fibrosis. He didn't have permanent lung fibrosis, but he went into acute hepatic failure.
Yes, there is some
Yeah.
patients may go into, then NAT will probably play a role, NAC.
Yeah. I mean, this was progressive, sir. Initially, he had some derangement, but with time, I mean, we had also shifted him
Treat
toward
these
an
cases like, paracetamol poisoning.
correct.
That may be rewarding.
Yeah.
Yeah, one small thing I want to add is that this poison paraquat again, most of the vascular organs, lung, kidney, liver, even heart, because any vascular organ is very well. Even muscles will be, it can rapidly distribute and absorb. So basically, the another thing is that when compared to the brain, because of that, it is not permeable to the blood-brain barrier. So the more patients will be definitely conscious. That is one thing. It doesn't
Yes,
penetrate into the brain. That's one just for
like
the students.
ALP, aluminium, these patients are
Yeah,
also
patient is fully
conscious
conscious, except for the brain, all other organs can be involved. That's
until
what.
the time of death.
Yes. Patient will be fully conscious. The brain is
Yes.
because of impermeability of the blood-brain barrier. Yes.
Do we have time for a couple more questions on OP poisoning?
There is a question about magnesium sulfate.
Yes.
Yes, sir.
There is
Magnesium sulfate on OP poisoning.
there is no role. It's
Yeah.
traditionally used for control of tachycardias and many other things. So it's an old empirical therapy which was used for many indications, but now it is indicated only for hypomagnesemia or non-responding hypokalemia. Intractable hypokalemia, magnesium therapy is indicated in some cases of Torsades de Pontis.
FFP in OP poisoning.
No role.
Edaveron, I think Dr. Ajit has also already answered.
But is it paraquat or OP poisoning?
I think it was for Paraquet most
Paraquat,
likely.
yeah. So
And
maybe the oxygen scavenger.
neither poisoning, no
Liver
role.
poisoning.
Yeah. Okay.
And one question I think related to Dr. Subhash's case, you stopped atropine and PAM too early. Yeah, even we felt that. I think even Dr. Rumta sir mentioned it. So generally, I think continuation of PAM and atropine for a little prolonged process generally helps. Is it, sir? Right?
Yes, otherwise most patients will have some signs of recurrence.
Correct. Yeah.
Reappearance of secretions in airways, some bradycardia, and we have seen one report because of early stoppage of atropine, there was cardiac arrest.
Yes.
Sudden. So it is always good to be, on the longer side of atropine therapy then. And has anybody ever observed toxicity of atropine?
Yes, sir, all the time.
Atropine toxicity?
Not toxicity, atropinization we have seen.
No, atropinization that we target.
Hmm.
You had to stop atropine and switch over to glycopyrrolate for reasons of atropine toxicity?
Sometimes, sir, because of severe restlessness in the patient.
Atropine psychosis, you mean to say?
Atropine psychosis.
No, and with what dose of atropine?
Significant doses, sir, infusions, I think.
Like 100 ampules, 200 ampules?
Yes, sir. Not
So,
so much. Not like 200, but we have seen, sir.
I say, and many other authors have also said, no dose of atropine is too high to manage OP poisoning. And my last case, we ended up using more than 3,000 ampules.
Right.
And
But,
I have not seen one case of atropine side effect or toxicity during my 30 years experience. We have managed almost 300 to 400 cases of OP poisoning consciously, but seldom we had to stop atropine. We had to stop atropine because it was not OP poisoning. We were treating something else for OP poisoning.
So there was
So-
one question. Yeah, yes. When to confirm the lungs are dry. See, the conscious patient who is unable to spit, and patient on ventilator, you're unable to have any kind of a secretion, man, because obviously the OP compounds will cause a bronchoria. That is the answer to that. That's how you confirm with this, and it is the airways actually, because the lungs, it's a secretion. It happened in the bronchoria. It's in the airway. That's what Dr. Rumtathar sir.
Ajit, I will warn about that, one time dry airway does not mean the lungs have become dry or airways have become
Yes,
dry,
yes, yes.
because
We need to closely monitor.
it's a paroxysmal occurrence.
Yes, yes,
Patient may be having dry airways for 10 hours, 12 hours,
yes.
or maybe 2 days.
Absolutely,
Third day,
absolutely,
you will suddenly find that the patient is having,
absolutely, sir.
because some of these OP compounds are deposited in adipose tissue and they are resecreted. Some of them are secreted into stomach and they are recycled.
Yes.
So some of the researchers have recommended gastric lavage or decontamination day 2, day 3, day 4 on theoretical basis. So be always ready until you are absolutely sure. Clean 48 hours. Never discharge the patient within 24 hours of recovery. Watch the patient for minimum 48 hours after complete recovery so that you are not to the blame.
So there is one question on OP-induced delayed neuropathy.
Yes, it is there.
It is there.
Yes, it is a very well-known entity and very, very difficult to diagnose, because most of these patients don't reveal that they had consumed poison and they recovered from it. And the team is left guessing. Because of social stigma attached with poisoning, they would seldom reveal that this particular patient was admitted with poisoning, and they said they had taken some medicine, was admitted for something. Probably some drugs have been given which has caused this. But most of the time patient would recover mostly. It's
Yes.
self-healing sort of neuropathy,
Yes.
unless it's something like intermediate syndrome.
Then there is another question on what is the time to stop atropine after atropinization, after dry lungs, I mean, that, and heart rate more than 100. So
Yes.
atropinization, I believe, is a goal rather than a endpoint. So we have to continue and achieve atropinization. So
Achieve and maintain.
and maintain, that's what. So it is
Right.
not an endpoint to stop atropine. It is a process to continue until we are free of the risk period. Like sir said, within first week, I mean, after up to first week, we develop intermediate syndromes and all. So we have to, generally, we would monitor for 14 days. If correct me,
Yes,
sir.
I think 2
Up to
weeks
14
is
days, yeah.
right.
And then totally, if there is intermediate, at least up to 3 weeks. So until then, we are always worried about all these things
So,
happening.
question specifically directed to me, management of Paraquet poisoning. Doctor, I think Ajit has described management of Paraquet very well. Only we have discussed things from discussion point of view and extracting more information from everybody participating here. So I think Ambu, it has been, you can take the recording from the host and go through the presentation of Dr. Ajit. It was very well presented. He has done it very well. Only thing is, I'm not too sure whether he should have used, because there are not many paraquat poisoning. There are few cases through the year, but we are not very encouraged to handle them.
I think, sir, one more question is there, Dr. Puja, for the Paraquet from Dr. Taditman, sir.
Yeah.
If the patient survives, what about the damage to oropharyngeal part, stricture formation in delayed cases, even after a week after ingestion, or mediastinitis if perforation occurs?
Mediastinus perforation are not very not rare in OP, this paraquat poisoning. In fact, some of the patients may present within few hours with esophageal perforation or even opening to mediastinum. So, but we are so lost in management of other manifestations of Paraquet. Usually we would ignore that because patient has endotracheal tube. Mostly the patient is on ventilator, patient has a Ryle's tube, patient is on dialysis or hemoperfusion, and we are always keeping our fingers crossed. So there is hardly any attention paid to mediastinum and esophageal perforation, and these patients don't live enough to develop strictures. So most of them will perish.
Correct, sir.
Correct, sir.
And if they come back, I don't think they come back to us.
And generally, whenever we talk of mediastinitis due to any reason, we always consider it to have 100% mortality. Majority of the times, that's what traditionally we have learned. But I think similar concerns will be there even with paraquet-induced mediastinitis.
Yes. Of course,
Absolutely.
mediastinitis, if paraquet poisoning patient has developed, that means it's a very high volume consumption.
Yeah.
That would mean, and the prognosis would not be good.
I think we're getting many questions. One question is how to differentiate between central effect of OPC poisoning versus other causes of drowsiness due to OPC.
Let Dr. Subhash answer the question.
Yeah.
Let
Dr.
the
Subhash?
presenter.
Sir?
Yeah. Subhash, will you like to answer this question?
Drowsiness.
Yeah.
So the question is central
didn't
effect of
understand the
OP
question.
poisoning. Yeah.
I didn't understand the question, madam.
How do you
What are
differentiate?
the central effects of OP poisons?
The central effects of OP poisoning through nicotinic, sorry,
No,
through M1 to
nicotines are
M5,
mostly
M1 to M5 receptors. Effects include drowsiness, sorry,
I think you mentioned it in your case also, na, initially?
yes. As initially we present with fasciculations, cramps,
so even
weakness
seizures,
and
patient may
paralysis.
present with
Seizure.
seizures.
The seizures.
Drowsy,
Yes, sir.
incoherent, seizures. There
Seizures.
was some
Fasciculations.
confusion about diagnosis. The OP poisons will smell, badly, garlic-like smell. So there should be no confusion. We don't need to use atropine or as a challenge test. You can smell OP from a distance. If you sometimes use OP compounds, most of these pesticides, if you are doing any sort of gardening, even small gardening in your balcony, sometimes you will put some pesticide. So you see, you will have a smell in your drawing room, living room.
So the answer to the question is that you rule out other causes for the drowsiness, Dr. Kavita. Other causes of the drowsiness in the patient, and this will be the diagnosis of exclusion. It's difficult to prove. Then you have to believe that it's because of the nicotinic
Unless
action.
many patients may have multiple, suicidal drugs taken.
Yeah.
But these, central effects will recover very, very fast. Atropine works like magic in these patients.
So one
I
more
think we have,
question.
yeah. Any more question, Dr. Pooja, or I think
I think one last question. After atropinization, how to continue atropine infusion or boluses, and what is the dose? I think again Dr. Subhash can answer.
Sir, after atropinization, the total cumulative bolus doses, that 10 to 20% of the total cumulative bolus doses should be started
As infusion, right?
as
Yeah.
infusion. Yes, sir.
And how to give boluses?
So actually, infusion is better compared to boluses.
No, but
Initial
initially
bolus.
you have to
Initial
give bolus.
boluses first to start with 2 mg. After every 5 minutes, we have to double the dose. Dose,
Correct.
4
Until
mg,
we
8 mg,
reach
16
the
mg until we
situation of
yes,
atropinization.
atropinization. After that, 10 to 20% of the cumulative bolus dose.
Subhash, I will like to suggest that we should not measure the atropinization dose and the follow-up dose in terms of what was the initial bolus and what should be the percentage of the initial dose used. It should all depend on the clinical condition and recovery of the patient. So we should continue to use atropine as low dose as possible if there is no appearance of secretions in the airways and the heart rate is all the time around 100 or above. So we should continue to use atropine. We should continue to reduce atropine doses and we should monitor and watch the patient for not less than 24 hours, what we will call complete recovery. Atropine should continue. And once the patient shows that minimal doses of atropine are not making any difference, then stop it and then give another 12 hours to the patient and our team to watch the patient. Then only you can say that no more doses of atropine are needed. And if you want to follow up the Baramati therapy, then you will have to continue PALM for 7 to 10 days.
I think the role of PAM in OP poisoning has been described very well by Rumta sir, I think, in our discussion. Dr. Anand, I think that's about questions.
Yeah, I think we have completed all the questions, and around 265 delegates have joined today's session. And I think that shows the best part of it. It's an excellent platform throughout India, students joining the session, and to the best of the examiners for this topic, for poisoning cases, Dr. Ajit and Dr. Rumta sir. I think it's the best platform and the best examiners. So, and the session going till 8:30. So, and I think
still
extensively.
I feel still can go on for another 1 hour.
Absolutely, sir. And we are honored that to listen again from you on this topic and from Dr. Ajit from this topic. So thank you for joining. And I would request Dr. Bhavani so to give vote of thanks.
Before that, I wish to congratulate the whole team, particularly Dr. Ranveer Tyagi for putting up this platform. Wonderful I'm coming here for the second time, and I have enjoyed second time more than I did enjoy on during the first time.
Absolutely, sir. It is Dr. Tyagi's initiative that has presenting real case scenarios and giving a practical exam scenario.
But my advice to the youngsters is to not to put any extra filmy material into the case presentation to look like it bookish picture. Let us discuss the real time scenarios.
Right, sir.
And action or detection from the real one really will deviate our attention to more theoretical considerations than actual one, because each case is different.
Right, sir.
Thank you so much for inviting me.
Thank you. No, thank you very much. It's a great discussion. Thanks for the opportunity. I would like to thank all the organizer and their ISCSM organizing team and all the students who participated in the discussion. Thank you, sir. Thank you, Ringta sir. Thanks, everyone.
Dr. Bhavani?
See you.
Thank you. It's actually a wonderful discussion. Actually, had a wonderful participation as well. I would like to express our heartfelt gratitude to our respected examiners, Dr. Narendra Rungta sir and Dr. Ajit Kumar, for taking the time to conduct today's case presentation. We are truly thankful for your valuable guidance, insightful questions, and constructive feedback, sir. I would like also to thank our mentor today for this session, Dr. Pooja Murthy, as well. And I would like to thank our fellow students, Dr. Ajit and Dr. Subhash, for their hard work and active participation, which made today's presentation meaningful and very much engaging. And not the least, our participants who have joined in very big number today from all over India for making this session very successful. Thank you all, and we will end this session.
Thank you. Thank you.
Thank you. Thank you, Ajit sir. Thank you, Rumta sir.
Thanks, sir.
And thank you, Dr. Pooja.
Thank
And all
you.
the delegates.
Bye. Good
Bye
night.
and good night.
Thank you, sir. Thank you.
Good night. Good